Can you see my screen?
Yes. Hello, I can see.
Can see, yeah? Okay. All right, okay, so we just continue the last lecture. So today we're going to talk about the myofunctional and orthopedic appliances, the part 2. So the first part we already talked about the myofunctional appliance. Then the second part we're going to talk about these orthopedic appliances. So what's orthopedic appliances? So orthopedic appliances is corrections of the skeletal pattern, then with the corrections of any dental ovular malocclusion being of the less important in which the little or no tooth movement is desired. So what you're trying to say is, we're using this orthopedic appliance, you're trying to change the skeletal pattern rather than the malocclusions of the dental ovular part. So we are changing the skeletal rather than dental ovular. So these orthopedic forces are heavier, which is about 400 grams, then compared to orthodontic braces forces, which is 10 to 120 grams. So what I'm trying to say is, we are going to move the jaw upper or lower, then you need a heavy force, which is about 400 grams above. Then compared to moving the teeth, then the teeth only use about 10 to 120 grams. So which is quite little. So if you want to move a block or you want to move a bigger subject, then use a heavy force. And if you want to move a small subject, then maybe use a small object, then maybe use a small force. So far as the philosophy of correction of skeletal discrepancy. So like we talked before, then if the skeletal discrepancy is mild to moderate, then maybe you can use the camouflage treatments or the growth modifications. When it comes to severe cases, then we have to do these surgical corrections, which is orthodontic surgery. So the camouflage treatment, we are going to talk about it later. But the growth modification is what we are trying to focus today. So the last part, we talk about myofunctional. This myofunctional mainly designed for the skeletal class 2 and class 3. Then we try to modify the growth when the patient is still growing. Then camouflage treatments in mainly still using the braces or the orthodontic appliances. Then trying to change the angle of the upper and lower incisor. So that's called camouflage treatment. But camouflage treatment is not changing the skeletal pattern by changing the class 2 become class 1 or the class 3 become class 1. So the class 2 still remain class 2, the class 3 still remain class 3. So we're trying to change or move the T around, then you're trying to do the camouflage treatment. So at the end, they give you a false impression, we correct the class 2 and class 3. But whatever we do is just changing the incisor angle or moving the T around. But the skeletal remain the class 2 or class 3. So what's the best option? It's not really the best option. It depends what the patient wants and what's the patient case. So like I say, the mild moderate, then we can try the growth modifications or camouflage treatment. When it comes to severe case, then it's best to deal with surgical corrections. So the basis for orthopedic appliances, then we have to talk about the amount of forces, then duration of forces, the direction of force, then the age of the patients, then the timing of the force applications. So there are so many types of extraoral appliances, then headgear, face mask, or chin cut. So generally, whatever used outside the mouth or extraoral, then we call it headgear. Of course, if you use it from the front, then maybe you can call it face mask. Then you just put on the chin, then we call it chin cut. So we're going to talk about this one by one. So what is headgear? So headgear is a group of appliances characterized by the extraoral positions or activating elements and supporting structures. So these appliances are individual or collectively called headgear. So maybe all of them can be called headgear, but usually at the back of the skull, then we call it headgear, and the front of the face, we call it face mask. And they have widespread use, then primarily because they have the advantages of remotely located responsive force, so encourage. So for braces, most of the time we do it intraorally. then we use the force that apply on the teeth. Then this is called intraoral anchorage. So when we come to extraoral, it means you're using the extraoral structures as an anchor. So mainly the skull, the face, the forehead, and the chin. So most commonly used excessive horizontal growth of maxilla. So let's say the maxilla is too long, with or without vertical changes along with some protrusion of the teeth. So this one we're trying to move the maxilla or restrict the maxilla because the maxilla is growing too forward. So there's this too forward or too backward, either one. And with or without vertical changes along with some protrusion of the teeth. So most effective in the preportal period, which means the patient is still growing a lot. So what's the component of this headgear? Is we have this force delivering unit, which is a face bolt. So it's on the top right corner. This one is called a J-hook or face bolt. So force generating unit, which is a spring or elastic, which attached from the cap then to these face bolts. Then we have an anchor unit, which is a head cap or the neck strap. So this one is a head cap. And the neck strap is something connect to the neck. So sometimes it can be a combination of the head cap and the neck strap. So we have something attached to the teeth, then we have something attached to the skull, then we need the elastic or spring to connect these two components, then make it one unit, which is called headgear. So what's a face bolt? Face bolt is a metallic component that help in transmitting the extraoral forces onto posterior teeth. So you see this headgear, they have this face bolt. This face bolt is connected to the posterior teeth intraorally. So usually we put the molar bands, then we have the buccal tube. Hello, can you hear me?
Yes. Yes, doctor.
Okay. I hear some noise. I'm not sure what's that. So okay, I'll just continue. So this face bolt will connect to this molar band, which is the buccal tube. So this face bolt, they have the upper or outer bowl, which is whisker bowl, then the inner bowl. So this inner bowl will connect to the molar bands. And this outer bowl, then this one will connect to the neck strap or the head cap with the rubber band. So the force generating unit, which is a spring or elastic. So this one is a spring. This one is a spring also. Sometimes we can use some rubber band, the elastic. So connect the face bolt to the anchor unit and deliver the force to the teeth and the underlying skeletal structures. So because you're trying to move the jaw, so the jaw attached to the teeth. So you're trying to attach something to the teeth, and hopefully the teeth will direct the force to the jaw, whether they're upper or lower. So what's the origin, direction, or active force? So it can be so many direction of pull. So if you attach the head cap to the parietal bone, then consider high pull. Then occipital consider middle pull. Then this one, the neck strap, consider the low pull or cervical pull. So parietal high pull headgear, because the force is quite vertical, then we can attach to the head cap, with the head cap and the neck strap. This one will give you the occipital pull, which is a middle or middle. Then we can have a low pull, which attached to the cervical or the neck strap. So this one consider low pull headgear. So anchor unit, it can be a head cap on skull or the neck strap on the back of the neck. So this is a neck strap. So most of the time, we use this combination of type of headgear. So it consists of both occipital or parietal and the cervical traction spring. So when the force exerted are equal, a distal and slightly upward force be exerted on the maxillary conditions and the maxilla itself. So we know the maxilla is grow in the downward and forward position. So to reverse this, we need the force which is upward and backward. So upward and backward. So this is how we reverse the growth or restrict the growth. So the force generated should be slightly tilted upward. That's the ideal force to restrict the maxillar growth. So what's the treatment effect? So even though we're trying to achieve mostly the skeletal effect, but inevitably then we achieve some tender effect also. Because the face bowl will attach to the teeth, so when you apply the forces through the teeth, then you will create some tender changes. So what's the skeletal effect? It's a compression of the suture. So namely all the suture on the maxilla, frontal maxillary, zygomatical temporal, zygomatical maxillary, thoracopalatine sutures. So all the suture attach all the bone on the maxilla, when it's subject to forces, they will be compressed. So the restriction and the forward, downward growth of the maxilla. So this one we'll talk about this. So you see the jaw of the maxilla will grow downward and forward. So to restrict or reverse it, then we have to have the force to pull this maxilla backward and upward. So no effect on the growth of the mandible because there are no actings on the mandible. So you see this headgear is nothing attached to the mandible. So we are not affecting the mandibular growth. So what's the dental effect? Because this appliance is attached to the teeth, it's considered the two-point appliance, which is the face bowl, that will cause the distalization of the maxillary molar. So we have a face bowl attached to the molar, then you're using the skull as an anchor unit to pull all the teeth back, then hopefully the maxilla will grow back also. So this one will create the distalization of the maxillary molar. Then extrusion or intrusion of the molar is seen depending upon the type of extraoral attachment. So for example, let's say I have a high pull headgear. Then you create the intrusion force and the distalization force. So if you attach to the occipital pull, then this one mainly is the distalization of the molar. So if you go for this cervical pull, then mainly you create the extrusion of the molars. So it depends on the direction of pulling. You create a different force, then you create different movement of the dental alveolar part. Okay, so what's the uses for this headgear? So the main purpose to use this headgear is to restrain the maxillary growth. So you don't want the maxilla to grow too much forward and downward. So if the maxilla is too long, so it's too protruding, then maybe we have to use this headgear to restrain the maxillary growth. So maintaining the arch length. So this one, usually we use it for the cleft patients. So sometimes you want to do some asymmetrical retractions or restrain the maxillary growth, then we use this. Then molar dislocations. So we talk about this because the face bones are attached to the molar bands. Then this one will cause the dislocation force of the teeth. And of course, sometimes we just want to reinforce and encourage, which you do want the molar to move forward. Then we can use the headgear also. So you want to restrain your maxillary growth, and you want to do some molar dislocation. So maybe you have to go more than 12 hours. Then if you just want to reinforce and encourage, you don't want the molar to move forward, then maybe you do less hours, maybe less than 12 hours. So it really depends how much you want the maxilla to grow back, to go back. If you want the maxilla to go back a lot, then maybe you have to increase the hours of wearing. If you just want to prevent the molar from moving forward, which is called encouraged reinforcement, then maybe you do it less hours. So what's the limitations? So dental changes are inevitably seen along with the skeletal effect. So even though we're trying to move the maxilla back, but because there's something attached to the teeth, so you cannot avoid to move the teeth because there's something attached to the teeth. But the teeth is linked to the maxilla. So hopefully when you're moving the teeth back, then maybe we will generate the force to the maxilla also, which will restrain the maxillar growth, and you're lucky, maybe you can move the maxilla back. So, but this one, the patient compliance is mandatory. So like we talked about this, the last lecture, whatever comes to removable appliances, the compliance is always ultimately the most important thing. So if the patient's not going to wear this appliance, nothing will happen. And this face mask or headgear or extra-order appliances, then you need the patient to wear it more than 12 hours. So if this cannot be done, then maybe the result won't be good. So adequate amount of mandibular growth is required to catch up. So sometimes if you move the maxilla back, then without the mandibular growth, which is mandibular growth forward and downward, if this doesn't happen, then you still end up in increased overjet. So this one we have to do it a bit of both. We have to move the maxilla forward, then we move the maxilla backward, then we're trying to move the mandible forward. By doing that, then we can reduce the severity of the class 2. Of course, this headgear is only for the extraoral, and which is trying to move the maxilla backward. So if this doesn't enough, then maybe you can add in the functional appliances, which we talked about this, the last lecture, the myofunctional, trying to move the mandible forward. So just now we finished the extraoral headgear, which is mainly used for class 2 or the maxillary access. Now we come to this reverse pull headgear, which mainly deal with the class 3 skeletal pattern. So it consists of a rigid extraoral framework, which take anchorage from the chin and the forehead. So you have something rest on the chin and the forehead, or both for the anterior traction of the maxilla using the extraoral elastic, which generate a large amount of forces. So you see this one, we have something attached to the forehead and the chin. Then of course, at the same time, we have something attached to the jaw also. So you're using the forehead and the chin as an anchor unit. Then you're using the rubber band, which attached to the maxilla. Then you're trying to pull the maxilla forward. So you need something extraorally, and you need something intraorally, and you need something to connect between it. So the same for the headgear and the face mask. So we have the earliest design, which is by Hickam. And first to use this reverse pull headgear. Then we have a delayer, which was popularized the reverse pull headgear in the 1970s. So what's the indications? So across this patient must be growing patients. Again, it's a mild to moderate class 3 skeletal pattern or malocclusion with the prognathic mandible and the retrusive maxilla. So just now for the extraoral headgear, they may be used for the prognathic maxilla. For this reverse pull face mask, then mainly to use for this retrusive maxilla. They will mainly deal with the class 3. So it can be used for selective rearrangement of the parietal shell in the cleft patients. So for example, for cleft patients, so mainly the maxilla will be underdeveloped, and maybe we can put it forward. But this because this maxilla is separate by the cleft, maybe sometime on the left segment and the right segment separated. So we can use a different force to pull the different segment forward. So the use in correction of post-surgical relapse after osteotomy. Sometime after orthodontic surgery, then if the surgeon didn't get the perfect result, then maybe we can use this reverse pull face mask to get the maximum result out from this orthodontic surgery or to prevent the relapse. So when sometime after surgery, if the result not ideal or the relapse a little bit, we can use this reverse pull face mask to help. So the site of anchorage is from the forehead and the chin. You see these two plastic, one attached to the forehead, then the other one attached to the chin. Then of course we have this bar to connect these two components. Then intraorally, we have something like the RME, rapid maxillary expansions. Then we have the hook to attach the rubber band to this reverse pull face mask. So biomechanical considerations. So we talk about this, the amount of force, because you are trying to move the maxilla forward or backward. So the force must be high enough. So we are talking about 400 above, 400 above. So for this reverse headgear is 450 grams per side. Then the direction of force is a 15 to 20 degree downward pull to the occlusal plane, which is a forward translatory motion of the maxilla. So we know how the maxilla grows. So the maxilla will grow into the downward and forward position. So we try to mimic the growth of the patient. So we trying to pull this maxilla in the downward and the forward directions. So the frequency of use, like I say, must be used more than half day. So 12 to 14 hours per day. So after the patients or the kid come back from school, then they have to wear this headgear or the reverse full face mask. It must be more than 12 hours per day, otherwise it won't work. So this means more than half day of the time patients wearing this headgear. So it's not easy, because it's more than half day patient wearing this walking around. They will disturb the daily activity. So the duration of treatment is about 12 months, which is about a year or less than a year. And after that, they follow by this monitoring procedure. It means after you achieve the result, then you monitor whether the result is stable or not. So duration of treatment is about 1 year. So the part of this reverse screw headgear, we have the forehead cap. Then we have a metal frame, which will connect these two components. Then, of course, we have intraoral appliance, which attach to the mouth or the maxilla. Then mainly this one is made by this RME, rapid maxillary expander. Then we have the elastic attached from the bar then to this RME. Then we have the chin cup. So the chin cup attached to the forehead, then using this metal bar. So this work as one component. Then we have the intraoral component. Then we have rubber band to connect these two components. So this one is the same, just a clinical pictures showing what is the chin cups, then forehead caps, then intraoral appliance. RME, this one is a rapid maxillary expander. They have the rubber band attached the intraoral to the extraoral. Then we have the metal frame. So, like we mentioned before, this headgear or reverse full face mask is not started by the protection headgear by the headcom. They have the two vertical metal poles from the chin caps elastic attached to the elastic. You see, initial design for this reverse full headgear, we have this design by headcom. So mainly you just have the chin cap, then with two metal bars sticking out. These two metal bars can attach a rubber band to the maxilla. Then after that, we have this face mask by Delay. So Delay, then they have this design which is better than Hickham. So you have the anchorage unit which is from the forehead and the chin. Then there's adjustable height of the outer bow, hence the force direction can be controlled. You see this extraoral bow, then this one can be adjusted the height according to the screw. So this screw can be loosened, then you can move this up or down. By doing that, you can adjust the force of directions. So then later we have this petite type, which is similar to Deleo face mask, except this one we have two rod, then we change to a single rod in the middle. So this petite type, I think, remain one of the most popular design at the moment because it's simple. So this one, sometimes if patient wear this Deleo design, then patient cannot turn left and right too much when sleeping. So this one will disturb the rod. So the chin cup, which is the final topic of today, this chin cup is the same, is one type of the extraoral appliance, then cover the chin and is connected to the headgear. So they used to restrict the forward and the downward growth of the mandible. So we all know the mandible and maxilla, they grow in the downward and forward position. So you want to restrict this, you have to reverse the direction of the pull or reverse the direction of the force. So we used to restrict this downward and forward growth in mandible. So you see the chin cap is attached to the skull. So of course the component, we have a chin cap which attached to the chin. We have the head cap which is attached to the skull. We have this adjustable elastic strap which connect these two components. Similar to the headgear, but this time we attach to the chin rather than maxilla. So there are two types. One is occipital pull chin cap, then the other one is vertical pull chin cap. So vertical pull, it means attached to the parietal bone. Then occipital pull, then mainly is attached to the occipital bone. So you see the design is the same or similar, just the direction pull is different. So occipital chin cut means the direction of force is directed to the occipital bone. Classic cases with mild to moderate prognosis. So most companies use this chin cut. So it's this type occipital pull. Huh? So then we have the other one, which is vertical pull. You see attached vertically, mainly using the parietal bone. So vertical pull chin cut encouraged from the parietal unit or the region, then high angle cases or long face patients. So you're trying to do some vertical adjustment also for this patient. So let's say patient have a long face, you want to restrict the growth of the mandible in the vertical direction. So you do this vertical pull chin cuts. So fabrications, it can be fabricated or custom made. So it can be hard or soft. So this hard chin cup then custom made from the plastic, and the soft one is made from the football helmet chin strap. So this attached to the chin. Some people will say the hard one will be better. Some people say the soft one will be better. But both actually I think work the same. The force magnitude and duration is vary. So initially maybe we do a bit less forces, maybe 100, 300, 150 to 300. Then over the next 2 months, force then we gradually increase to the 300 to 600. So again, this one must be more than 400 in order to generate the result. So when we move the jaw, maxilla, or mandible, you need high forces. Then if you want to move the tail only, then maybe use low forces. So it's about 12 to 14 hours of day. Again, this one is more than half of the day. So get the desired result. So you want to move the jaw, then you need the long hours and high force. So the ideal patient for chin cut is a mild skeletal pattern or mild skeletal problem, which is about 4 millimeters reverse overjet in a child. So the ability to bring the incisor edge to edge. So usually they ask the kid trying to retrude the mandible, then trying to achieve the edge to edge bite. So if they can do that, then it's a good case to start the chin cut. Then if they not manage to do that, I mean the skeletal problem is more than mild. Maybe they will consider moderate case, which is not suitable for chin cut. So short and normal vertical face height. So we'll talk about this. So this one can do the occipital pull, parietal pull. Then this one will create different forces. So short or normal vertical height usually is better. Normal position or protrusive, but not retrusive mandible, lower incisor. So this is because the lower incisor, if they are already retroclined, that is usually considered compensated, which means the patient have a more severe skeletal pattern. So this kind of patients then may be not suitable for the chin cut. So what's the conclusions from these 2 lectures? We know the function appliances help in interception of the developing malocclusion by changing the direction and amount of growth. So proper fabrication of the functional appliance also play important role during the treatment period. So you have to fabricate this appliance accordingly. So you can modify this functional based on your needs or the patient need. This one have to be properly done and designed. And we also have this extra order appliance or extra order force therapy in the form of the headgear, which largely dependent on the patient cooperation or compliance. Hence, along with the clear understanding of the treatment modality, it is essential that we motivate our patients to be regular with it until the desired goal are achieved. So what I'm trying to say, the compliance from the patient is ultimately the most important thing. So when it comes to removable appliances, if the patient's not going to wear it, then nothing much will happen. So patient have to wear it according to the instruction, which is more than 12 hours a day. So for functional, there may be more than 12 hours a day. We request the patient to wear it 24 hours except eating. So for extra oral, of course, you want the patient wear it full day, that's the best. But no one can wear the headgear walking around for more than 12 hours. Because when they go to school, then if you ask them to wear the headgear or the face mask, then the friends or the colleagues, the friends or the classmates might be roughing at them, then they will feel confident or they feel comfortable. So we ask them to wear it after school, which is about 12 to 16 hours per day. So do you have any question to ask me? Hello.